To treat ischemic MR or not is the big question. And in fact, in most of the patients who have ischemic cardiomyopathy, the development of mitral regurgitation worsens the heart failure very fast. It is said that in heart failure patients, if there is severe mitral regurgitation, conservative management has very poor prognosis, and the 1 year survival of these patients is only 30 to 40%. Means imagine case 60%, more than 50% people are dead at the end of 1 year if you do not do something for ischemic mitral regurgitation. This is primarily the pathology. When there is an MI related to the circ or related to the right coronary, more frequently than not, the posterior papillary muscle moves outward and downward, leading to tenting of the papillary chordae and taking down the mitral leaflet, leading to mitral regurgitation. There is a significant distortion of the mitral valve annulus in the area of P2, P3, and that is where the real main jets come from. Basically, the whole posterior leaflet is dragged down, leading to incompetent valve and MR. So what we have to realize, it is not a problem of the valve, it is a problem of the geometry of the heart that leads to the ischemic mitral regurgitation. So it's a geometric ischemic MR. So what do we have to consider when we are addressing mitral regurgitation? One is, how is the myocardium? Is the myocardium good or bad? What are going to be the results of treating mitral regurgitation? If we don't treat it, what is going to happen? If we treat it, what is going to happen? What is the grade of MR? Is it moderate? It is severe? Is it significant or not? And what would happen if we do only a CABG? What happens if we do CABG and mitral valve repair? Because there's a lot of controversy that surrounds it, and in fact, I think this is the most controversial topic, treating of ischemic mitral regurgitation. Many a times in the theater, if we try to do an intraoperative assessment of MR, it would not be right, because under anesthesia, the grade of MR can change. So there is a lot that has to be thought. First, moderate, should be treated, not be treated. Normal size ventricle, severe MR, should be treated, not be treated. Then how should it be treated? Repair or replacement? So that is the whole controversy. Whenever an echo is done for mitral regurgitation, it's very important to quantify the amount of mitral regurgitation, what is the type of mitral valve deformation, and how is the left ventricle in relation to the mitral valve. Because based on that, you will decide what to do, whether to replace or repair the mitral valve. This is how a severe mitral regurgitation would look like on an echocardiography. The LV is dilated, the leaflets are tented, and there is severe mitral regurgitation. You can see it's very significant tenting. The leaflets don't come up to the annular level. So that is basically the pathophysiology of mitral regurgitation. And if you measure the tenting, it will be significant. That leads to mitral regurgitation. Essentially, what it means is the chordae keeps the mitral valve leaflets from coapting, and the coaptation happens at a very low level, and even the length of coaptation is much less than what is required. Sometimes the leaflets are just kissing one another and keeping the mitral valve competent, so that's not good. Like I said, the debate would be moderate MR, to treat or not to treat, severe MR, whether you do a repair or a replacement, and is there a role of TEER? Now, if you're treating ischemic mitral regurgitation, there are several things that you need to do. So one is coronary artery disease, whatever it is, we're talking of ischemic MR, that needs to be addressed. Mitral valve annulus, is it dilated, not dilated, is it distorted, not distorted? So the mitral valve annulus will have to be addressed. The subvalve apparatus, many times there are a lot of chordae that are tethered, the basal chordae that are pulling the mitral valve and the annulus down, leading to distortion of the annulus and thereby mitral regurgitation. So it needs to be addressed. Many times, even after doing an annuloplasty, the leaflets won't be coapting properly. So sometimes the Alferi stitches are required. You need to repair various clefts, and occasionally even the papillary muscles have to be brought together to address ischemic mitral regurgitation. And many a times there is significant ventricular remodeling, or there will be lateral wall aneurysms which need to be plicated or repaired to bring or to make a valve competent. The approach is, our approach is actually, we use a two-stage cannula. We don't even do separate SVC, IVC cannulation, but I think SVC, IV cannulation is good. Go through the interatrial groove. It is very, very important to dissect well into the interatrial groove. The second thing that I always recommend is that the right side pleura should be really taut, it should be brought up as much as possible to try and rotate the heart towards the left side so you can see the mitral valve, because the left atriums are very small in these cases and many a times it's impossible to see the mitral valve annulus. Standard annuloplasty sutures are taken. If you can't see much, you can go into an extended transeptal approach. This is what we do essentially. I start taking stitches from somewhere around P1, go around the entire mitral leaflet and go around the mitral annulus. Last stitches that I take are at the top around the anterior mitral leaflet, and once that's done, the sutures, the ring is tied down and the mitral valve becomes competent. So more frequently than not, all that's required is a mitral annuloplasty ring to bring down the size and thereby make the mitral valve competent. Occasionally, if you feel there's a lot of tenting, you can put a L-Ferry stitch at the level of A2P2 because A3P3, because that is the point at which there will be maximum tenting. This is a 3D echo showing a competent mitral valve. So like I just mentioned, the most important pathology is the downward and outward movement of the posterior papillary muscle, leading to the dragging of the P2 and A2 areas. So any ring that does a reduction of the anterior posterior diameter would work to control ischemic mitral regurgitation. Most of the patients, they benefit with undersized ring annuloplasty, so you should go at least 2 sizes down when you try to do a mitral repair for ischemic mitral regurgitation, because of the tenting. If you put a true sized mitral annuloplasty ring, you will not get a competent mitral valve. So if you are attempting repair, it has to be 2 sizes down. We were the people in the world who implanted the highest number of the geofoam rings. They were excellent rings, lower left side, for mitral valve repair, but now that is no longer available. So right now we are using 3D profile ring from Medtronic for repairing ischemic mitral regurgitation. We try to prefer the ring that is the least AP diameter because that helps in giving more competent valves after repair. Now, as I said, the debate is about repair or replace for ischemic mitral regurgitation, and I'm sure all of the surgeons present here, they also have a debate in their heads, should I repair or should I replace? So there was this meta-analysis by Christopher Cow where he studied a lot of patients and he came to this particular analysis that the mitral valve repair is associated with significantly reduced late mortality, that is 16% versus 22% for repair. And he believed that beyond 36 months, this is very apparent that the mortality will be less if repair is done than replacement is done. He also mentioned that thoracic surgeons from 2008 to 2012 reported that mitral valve repair occurred in almost 2/3 of the mitral valve surgeries in patients who underwent concurrent coronary bypass surgery. Though data was not there, though they did not know what is good for the patients, surgeons have pursued repair. 2/3 of the surgeons pursued repair and were not in favor of replacement. There is this huge meta-analysis by Kristina Vasileva. Again, she also said that repair mortality was more than 2.5 times greater in the replacement group than in the repair group. So once again, this data also said that replacement is associated with mortality. And she said that based on the meta-analysis and literature available, mitral valve repair for IMR is associated with better short-term and long-term. So she said both short and long-term things are better. So it's always about a discussion of mortality. What was the mortality benefit? So two meta-analyses both stated that repair is better than replacement. Then I don't know whether any one of you has read these two articles. Two major papers came out from CTS network group. This was a group of surgeons in Europe who got together to study whether mitral repair should be done or not, and these were randomized trials. The first one was for moderate mitral regurgitation, where they proved that moderate mitral regurgitation should not be treated. It should be left alone, especially if the LV is small, hibernating and normal. Don't do anything, leave it alone, the patient will be okay. There is no mortality, morbidity benefit by repairing for ischemic mitral regurgitation. However, in this study, where they compared severe ischemic mitral regurgitation, and this was done by Ecker et al. For the CTS network group of surgeons. Here, 50% went for angioplasty or annuloplasty and 50% went for replacement. And they found out that at 2 years, there was, according to them, they said there was no, why, that's pretty loud, no benefit in, there was no benefit of repair over replacement. And in fact, they said that at 1 year, they saw a lot of mitral regurgitation in repair group, whereas in replacement group, there was no regurgitation. And this led to a lot of mortality in the repair group. And hence, based on this study, it was concluded that replacement is a better option than repair for ischemic mitral regurgitation. And after this, the guidelines changed towards trying to do replacement and not repair for patients with ischemic mitral regurgitation. However, the Duke University experience between 86 to 2006 also proved that repair is better. Again, the Stitch trial had also proved that repair is better, as you can see by the green line. And then Rankin et al. Again studied whatever had happened in the primary trial, CTS network trial, by the CTS network group, and he came up with some conclusions. He said that the group of surgeons who were involved in the study by the CTS network group had not done proper downsizing of the rings. Their ring size had been 31. They had not done subvalvular procedures, and the repairs were not detailed as to what repair had been done. And that is why the repairs had failed. So he said that if proper repair is done in ischemic mitral regurgitation, where you repair the subvalve, you repair the chordae, you do whatever else is necessary, like bringing back the papillary muscles together, putting extra chordae, cutting basal chordae. If a complete, successful, good documented repair is done, then they could have reduced the recurrence of mitral regurgitation and reduced the amount of mortality in repair group. So there were a lot of redundancies in that trial, and hence he believed, and most of the data now believes, that maybe repair is still better than replacement, though the guidelines and current data in the literature says different. This was about something done by a group of surgeons in USA, where they collected the data as to what they were doing for ischemic mitral regurgitation. And in this meta-analysis, they showed that mitral clip procedure does not confer significant benefit. Please hear this carefully. Does not confer significant benefits in terms of mortality and repeated hospitalization in patients with MR, number one. Number two, in moderate MR, the adjunct procedure of mitral valve repair is not important because it is not associated with any extra clinical improvement. And for patients requiring surgery with moderate to severe ischemic mitral regurgitation, mitral valve replacement is associated with increased mortality but with reduced reoperation. So you get a reduction of reoperation at the cost of mortality, which is not good. And mitral valve repair using annuloplasty is having less early mortality. And they analyze the data that over years what have surgeons done. So as you can see, still mitral valve repair is the most common procedure performed. After that there is replacement, and very few people are addressing moderate mitral regurgitation. This is surgical data from a group of surgeons who meta-analyzed their data, and this is what they proved. So whatever literature says, whatever guidelines says, still mitral valve repair stays as the treatment of choice. CTS network trial has kindled interest. Maybe repair and replacement should be recompared, that replacement is a durable solution. There is no recurrence of MR in replacement, but it is associated with a high mortality. So replacement comes at a risk of mortality, whereas repair comes with a risk of recurrence of MR. But full geometric annuloplasty, good annuloplasty with reducing annuloplasty rings, subvalve repairs, extra chordae, basal chordae reduction may give better results in time to come. Current guidelines of ECS say that if there is severe ischemic mitral regurgitation and it needs CABG, we can do one of the two, repair or replacement. If there is severe MR and no revascularization is possible, then TEER may be used. If it is moderate IMR and needs CABG, then isolated CABG may be good. And if there is severe MR with severe LV dysfunction, then these patients would be candidate for heart transplant and not or left ventricular assist device, whichever is okay. This is the COAPT criteria. So patients who are headed for TEER should satisfy or fall into these criteria. So essentially, in patients having ischemic mitral regurgitation, if it is moderate, one should leave it alone, just do a coronary bypass surgery. If it is severe, and if there is not too much stenting of the posterior mitral leaflet, like the mitral leaflet is not totally dragged down by a basal aneurysm, or submitral area is there's not too much of stretching of the posterior mitral leaflet, and if there is a way that the leaflet can come up with annuloplasty, then maybe a repair should be done. However, if the LV size is huge, there is a lot of traction on the posterior mitral leaflet, in these patients there will be a higher recurrence of mitral regurgitation after repair. Then in those patients, mitral valve replacement may be considered. If mitral valve repair is considered, it is imperative that we try to preserve as much chordae as we can, anterior, posterior. There are ways of preserving both the chordaes. Try to preserve the chordae for better post-operative left ventricular function preservation. However, whatever we do, repair is with less mortality, replacement is with higher mortality. Repair has risk of recurrence, whereas there is no recurrence in replacement. So basically you have to try and do a consistent mitral repair. It takes a lot of time, a lot of exercise, and in adjunct to all this, it is essential that good medical treatment be done, like the cardiologists keep talking of 6 pillars, 8 pillars, 10 pillars, and they're keeping on increasing the pillars to keep the heart supported on pillars. So that is equally essential after treating patients with our surgical maneuvers. I think I'm right, VC. What do you say? Thank you very much, everyone, for your kind hearing. Thank you.